Thank you once again for joining us for today's session on the effects of the opioid crisis on chronic pain patients and how that's managed. My name is Sean Patenaude. I am a patient engagement facilitator at the Center for Addiction and Mental Health in Toronto, and I will be moderating today's session. We will ask you, we would very much like to take your questions, but we'll ask you to put them in the chat and we will address them at the end of the presentation. And with that, let me introduce our panelists. So first off, Nicole Bartlett is an occupational therapist at the Center for Addiction and Mental Health in Toronto. In 2012, she developed the first OT role on the outpatient addiction treatment team. She promotes substance use and chronic pain recovery with a focus on behavioral activation, vocational rehabilitation, and relapse prevention. And she's also a founding member of the Interprofessional Pain and Addiction Recovery Clinic, IPARC, in the Toronto Academic Pain and Medicine Institute Network. Jessica Monroe completed her nursing education at the University of New Brunswick in 2000 and completed the nurse practitioner program at Dalhousie in 2004. She worked in primary care until 2020, most notably with the Sinai Family Health Team, where she helped to develop and led the award-winning chronic pain management program. Jessica joined the Interprofessional Pain and Addiction Recovery Clinic at CAMH in 2022. Kylie Payne has a Bachelor of Science in Psychology and is a postgraduate in mental health and addiction. She is a proud member of the Patient Advisory Committee and the Acute Care Quality Council at CAMH. In 2019, Kylie was diagnosed with hypermobile Ehlers-Danlos syndrome through the Toronto General Hospital. Chronic pain is part of her daily life and can make life challenging, and she finds being an advocate for mental health in the chronic pain community rewarding. And finally, Sandra Veljovic is a clinical pharmacist at the Center for Addiction and Mental Health and a graduate of the Leslie Dan Faculty of Pharmacy. She worked within several interdisciplinary teams, including the Interprofessional Pain and Addictions Recovery Clinic, the Concurrent Outpatient Medical Psychosocial Addiction Support Service, and the Mental Health Program at CAMH. Her primary area of focus is chronic pain and addictions. Welcome, everybody. So I want to start with Kylie because we wanted to talk about the experience of chronic pain patients as well as how they're being treated. And for that, it's really best for us to just start with an understanding of what it's like to be a chronic pain patient generally, and then we can move a little bit more forward into how today's environment affects things. So Kylie, can you tell us a little bit about yourself and about what your life was like before you began to suffer chronic pain?
Well, I've always noticed that I did have pain when I was a kid, but I was always told it's growing pains. So it was always like I'd hurt myself in random ways, and it was always growing pain. So I noticed in school was tough for me because exams and stuff were tough on writing, and I ended up getting resources for anxiety so I could prolong writing. But when I look back, it was more or less because I was experiencing pain. So what I found was I was doing good. So I had good days, but I started getting stronger, and I decided that I was going to be adventurous. So I started doing martial arts and getting into all those things. I snowboarded. And then I got into horseback riding, and I thought, hey, this is amazing. And so I thought, I'm going to be this active person. I went to school for psych, and I did a postgraduate in addictions. So I was working at a farm it was going to be an animal sanctuary and a women's sanctuary. So animals working with women. So then I ended up having a fall. I fell off a horse, not the funnest experience, I'm going to tell you. And that is where my journey with opiates and pain really began. I found life became very complicated. So what I decided to do was because of the pain, I actually broke my fib and tib before that. But when I fell off a horse, I broke so many ribs. I cracked a pelvis. I was just not a happy little camper. So I was prescribed opiates for pain reasons. And what I thought, I actually worked in addiction, so I was a harm reduction worker. So I actually was a part of the needle exchange program. So I actually saw a live, I witnessed pretty sad environments where people were in their addiction, and it was hard, like seeing patients. I say patients, but so you'd make friends with these people, and then they wouldn't be there the next day. So that was heartbreaking. So when I started on opiates, I started to really get in my head about it, especially from a background of addictions. And my family members also kind of got on my back. Not so much. It was more like they were concerned that I was on opiates, and I think I kind of caused that on myself too because I was in my head about opiates. So I decided to take myself off cold turkey, and I was terrified. I always say this, like it does, like I don't know, I might be dating myself here, but the movie Trainspotting, there's that moment where everything is surreal and there's babies crawling, and I honestly felt like that. It was pretty scary, and I know this. Like I went to school for like addiction. So in my head, after I'm like, why did I just cold turkey it? But I got in my head about it. So then I decided that I didn't want anything with opiates to do with opiates because it was scary, and I decided maybe that's not the right thing for me. I started going to a pain doctor, and I was getting lidocaine injections in my face every day, and it was very difficult because injections are not fun, and it's a lot to go 2 days a week. And then I was still not finding much success from that. So then I was recommended Suboxone. So I was actually taking Suboxone. So that gave me a very eye-opening experience. It was different. I was now at a clinic um, where I felt kind of a lot of stigma because in the clinic I went to was a pain clinic, but then in the real world, I was going to do my medication and the pharmacist was watching me. And people in the store were watching me. And like there were certain pharmacies where I had to go to a certain spot. I was on camera. It looked like a scary place, like where I had to go, had like the big like caution, like not a caution sign, but it was just a scary place to be, knowing that I was on camera, and that I already had stigma on myself for being on opiates, and then of course being on camera, and it was the fact that I had to go on Christmas, New Year's. It was that constant like reminder that I was on this medication. Turns out I ended up being allergic to it. So then I tried methadone, and that was a bit more serious because I was monitored more closely. And I had to drive out of my, well, I don't drive, but I had to get a family member to drive me to, get it every day, every weekend and stuff. So it was challenging. And then again, I had allergic reaction. So then I had to go off synthetic forms of opiates, and it was quite a challenge. Now, my biggest thing with being allergic to an opiate is when I go to the hospital for any kind of treatment, the long list of every opiate comes up on my chart. And this has affected my treatment significantly. I feel very stigmatized when I go to the hospital because they kind of confirm, oh, you're allergic to Suboxone, like, you know. So it's a bit tricky to navigate. And I noticed I was having really bad experiences at the hospital because that was being flagged. And I, most of the time when I was going to the hospital, I was going for like to see if I broke a rib, to see if I did this. And I always felt like I was being judged right away. I had an experience where a nurse called me aggressive, and it was heartbreaking because I wasn't. And so, anyways, when I left, so they're like, she's like, no, you don't get anything, you have to leave. So I left, and then in my head, I'm like, what do I do? So I actually ended up going through a merge, and I was able to see a doctor. And then when I saw the doctor, there were two security guards outside the door, just to like, you know, because supposedly I was aggressive. And then when the doctor came to visit me, I was just like, could I just get a shot of Toradol and be on my way? Like, that's all I want. And he was like, you don't even seem aggressive. So what's that about? And to make matters worse, I was really upset about that experience. So I went back and it wasn't in my chart. So that was a bit concerning too. I had another experience where I had a mini seizure. So I'm probably getting all over the place, but I have hypermobile Ehlers-Danlos. So there's a number of complications that come with it. So yes, I am like, I don't know if you can see, like I am like flexible beyond flexible. And I have a heart condition, and I also have, so I have post orthostatic tachycardia, and now I'm getting tested for mast cell activation, which is being allergic to everything. So that's why they're finding all these sensitivities. So there was one time where I got up too fast, passed out, I hit my head, and they called they called the 911, they came, they put a catheter in, they put all this stuff in, and then I went to the hospital. So they thought I OD'd, like, because I couldn't communicate. So they started taking, so they put a catheter in, they did all these tests. They found out that I had nothing in my system. And I think as a human and somebody who advocates for patients, this was one of my worst experiences because they pulled everything out after. They pulled the catheter out, they pulled all the tubes out, and let me sit there. They said, you have 5 more minutes here, and then you have to sit in the waiting room for crisis. Meanwhile, fell and I had an injury, and they're treating me like I OD'd, which for me is sad in itself, because if somebody, now I'm relating to the experience of somebody being in the ER and that stigma that's created on them that they OD'd or used drugs, and they're not treated like a human, or like respected as somebody who is in need and needs treatment. And so I was very fortunate because I was able to get into Toronto General. So it's called the New Hope Ehlers-Danlos Clinic. So there I was able to get an official diagnosis. And it was amazing because I was struggling for a while because I didn't have a diagnosis. And then I had all these allergies and sensitivities. So things were being questioned. And when I got the diagnosis, it was helpful because I was able to use this service that not a lot of people are able to access because of the wait list. And I learned that opiates are the only thing they can give you for Ehlers-Danlos syndrome. So they say physio and opiates are your biggest help. So then I have this big dilemma again. Do I go on opiates? Do I not go on opiates? And I was able to go through this program, and I found the most successful thing for me was pain psychology. I learned that I have a purpose, and sometimes you get hopeless because you have that stigma and you have chronic pain. and you feel like you can't do anything. And I realized that I'm bigger than what I am. I'm bigger than my diagnosis. I realized that I have to use what I've been through to speak and advocate, because I'm still learning to advocate for myself. Oops, I dropped the earphone. So I'm still learning to advocate for myself, and I'm learning that pain psychology is another aspect I never thought of. And I think, as somebody who suffers from chronic pain, it's hard to deal with your mental health, because it's like you have your chronic pain, and when it gets loud, it's hard to just maneuver life. And I feel, as someone who's spoken to a pain psychologist, it was very helpful, because I could tell this doctor things that I can't tell regular doctors, and they would understand where I was coming from. The fact that I have a treatment team is amazing, because not a lot of people have access to it. But it's learning how to stop and smell the roses and realize that life is still beautiful. And I think that's important.
Kylie, thank you so much. You couldn't have set the scene better for the discussion that we want to have. And I'm really glad that you found care that works for you. And I think with that, we'll invite the clinicians from the iPark Clinic to come in and talk about how they deal, how they serve clients with chronic pain.
Thanks, Sean. That is certainly a tough act to follow. Thank you so much, Kylie, for sharing that really invaluable perspective. As someone living with pain, I was struck by just how powerful that reminder is about stigma, stigma in society, stigma towards oneself and in the healthcare system. And also the key things that you talked about that really positively influenced your own recovery journey, things like the pain psychology and the other areas around pain aside from just medications. So in our brief presentation today, we will be approaching this important topic from the standpoint of healthcare professionals. First, we're going to just concisely do an overview of the chronic pain service and comprehensive assessment service that we offer. Secondly, we want to set the stage around the current landscape of chronic pain treatment, particularly within the context of the ongoing opioid crisis. We also will present a compelling case study from our own practice that highlights some of the challenges and successes that we have come across in the treatment of chronic pain. And lastly, through these talks and through the Q&A afterwards, we hope to equip you with some practical approaches and strategies that you can take with you in your care of patients and also in dealing with yourselves with pain. So before we get into that, I just want to highlight that we do not have anything to disclose in terms of biases, so nothing there. Okay, so to first provide some context for our presentation, let's set the stage with some background information. So for those of you who are unfamiliar, I'd like to introduce you to TAPME, which stands for the Toronto Academic Pain Medicine Institute. TAPME is a comprehensive interdisciplinary academic pain hub in Toronto. It was established in 2017, and it was designed to optimize service delivery to make sure that patients enter the right door from the very beginning. So to do this, they created a centralized referral network so that you could basically streamline service. So whether you're a primary care provider or someone living with pain, a referral to TAPME will guide you to the appropriate hub that will align with your specific needs. So today, we're proudly representing one of those specific hubs known as iPark, or the Interprofessional Pain and Addiction Recovery Clinic, which operates within CAMH. And our hub is dedicated to addressing the unique challenges posed by individuals who are managing chronic pain, as well as co-occurring substance use disorders and or complex mental health. So we are a pretty big team, and we consider ourselves to be extremely extremely fortunate to be part of this vast interdisciplinary team. We understand that not everybody who's attending today will have access to such a valuable resource and team. So we acknowledge the difficulties that can really arise in managing chronic pain without this level of access. So in light of that, we wanted to we'll share some resources towards the end of this talk that might help you with navigating care. And we provide both interdisciplinary and comprehensive assessment and treatment to address all aspects of a patient's well-being. So not only just the physical pain, but other aspects, things like Kylie talked about in terms of addressing people's goals and things that are important to them and meaningful to them. And we also collaborate very closely with primary health care providers in the management of care once people transition back to their providers. So now I'll pass it off to Jessica.
Thanks, Nicole. So I just kind of want to set the stage with a quick poll for the providers out there. The question is, how comfortable are you with prescribing opioids for chronic non-cancer pain? So thinking about things like fibromyalgia, chronic widespread pain, chronic low back pain. And I don't know, did the poll come up? There we go. So just a quick little poll to just get a sense of our audience. And it's not a test, it's really, we're just sort of curious how people are feeling out there. Just give it another 20 seconds or so. Recognizing that not everybody's a prescriber out there, so we won't get 100% of people voting. Okay, so maybe we can end the voting. We got about 30% of people. And so it says, so it looks like really the majority of people are not very comfortable. So we've got 13% are not comfortable at all, and 14% are somewhat comfortable, but only about 5% are very comfortable. And then, of course, lots of non-prescribers in our audience. Okay, we can stop sharing that. And so, you know, that really kind of aligns with what we're seeing out in the world and in the community. There have been studies that have shown in Ontario that GPs up to 40% and sometimes higher are not comfortable prescribing opioids or flat out will not prescribe opioids for chronic non-cancer pain. And so it's really been a shift, I would say, especially since about 2010. So 2010 sort of marks in my mind when the opioid deaths really started increasing sort of exponentially and steadily and not just little blips. And before that, for those of us who've been practicing since before 2010, you know, I grew up in an era where pain was the fifth vital sign. It was on every nursing unit. It was part of the chart. It was really, really pushed to talk to patients about pain, which I think is really important and relevant. But at the same time, there was really, there wasn't a maximum dose. There was no ceiling for opioids. And a lot of that came from big pharma, as we know now from the whole Purdue fiasco. And there really wasn't a safe prescribing framework that we were taught, right? In school, it wasn't part of the guidance. And there was no education or mentoring or sort of knowledge about how to go down from there, how to stop once you got to a certain point or if it wasn't working. And if patients got into trouble, which was not uncommon, it was seen as a defect in the patient rather than a problem with how we were prescribing things. And a lot of patients, like if you look at statistics of patients who end up with a substance use disorder to opioids, a very large percentage of them started with a prescription after surgery or for some, you know, prescribed pain reason, often acute pain. And then, you know, things went sideways, but really, like, there's two people, there's a prescriber and there's a patient. And I think, you know, we weren't very good about taking responsibility for any of that. And so now we've got this landscape of sort of the polar opposite, where people are afraid of opioids, people don't want to prescribe opioids. And then there's all this stigma around some of the safer options that we have, like buprenorphine and methadone. And there's really not a lot of support. We still don't have very good chronic pain education. I'm so proud to be part of the U of T Interdisciplinary Pain Week, where we actually get to talk with, social workers, nurses, doctors, dentists, physio, all together in one room about managing pain, because I think that's a real shift in how we're teaching it. But there's still really a lot of misinformation, miseducation, and support. There just isn't the education and support about how to prescribe the opioids. What I would say though is that we're better about guidelines. We have the opioid, the McMaster opioid guidelines that talk about how to safely start a trial, how to finish a trial, how to do a rotation, but they're not as accessible as they might be. And so in our experience, we get sent patients often under duress. So, providers get a patient, maybe they inherited them, and they're on high doses of opioids, and they sort of panic. And so they send them to us really with sort of a request to get them off of opioids, is often there. And, you've got a patient who says, but this has been working for me for years and I don't want to change anything. And why am I coming here? And then there's stigma around it being CAMH too, right? That it's a mental health institution, which is still a stigma we all have to overcome in society. And so patients maybe don't want to be here. They feel like they have to be here. They feel like they're being penalized. I think what we often hear is from patients is, this whole opioid crisis, and it's about the fentanyl users, but I'm not a fentanyl user, and I'm not a number, and the drugs are working fine for me, and I just need more, or I just want to stay on the same, and just feeling sort of chastised about it. And change is really hard and scary. And a lot of them might have had the experience like Kylie had, where they went cold turkey, or maybe something happened with a prescription, or, something didn't get faxed to the pharmacy and they ended up in withdrawal. And they remember that horrible experience, because it's terrible. It may not be life-threatening, but it's absolutely awful. And so they don't want to go through that again. And so that's really frightening as well. But at the same time, from a prescriber's perspective that's sending patients to us, they're worried about their patient. They're worried about safe prescribing. And, those opioid deaths are still going up. There have been about 8,000 deaths in Canada in the last 2 years per year. And Ontario's the highest rates of opioid overdoses. So, it's scary on both sides. But so they come to us, and we sort of have to unpack all of that. And so what do we do? I think the most important thing we do is we really try to establish rapport. One of the first things I say to patients is, I can read your chart, I've read your chart, but I want to hear it from you. I want to hear your story, because the chart, they're words from someone else, and I need to hear it from you. I need to hear your experience. And then we can really validate those stigma experiences, those negative experiences. There's often a lot of medical trauma. And, that's not in the notes from the specialist. The specialist doesn't write about how they dismissed the patient, but you need to hear from the patient if they felt dismissed. And then we do a lot of education around the rationale for opioid guidelines. I hear what you're saying about the opioid crisis, but also there's all of these really big scale studies that show these things that we worry about with opioids. And it's not just about addiction. It's about lowered testosterone and lowered thyroid function and decreased bone mass and sleep apnea and dementia and falls and depression. And those things matter. And now we know that about opioids, where we didn't know that before. And these are the risks, and we need to talk about the risks, and they're important. And then shifting the conversation, like Nicole said, we really try to focus on, we categorize into 3 sections: mind, movement, and medication. And you can't just have one. We don't just prescribe. You need to be involved in treatment plans and goals, and we need to work with you. And then really offering support. A lot of our patients, especially those with fibromyalgia, chronic widespread pain, have central sensitization. And so they're sensitive to everything, and that means medications too. And so sometimes they need to try a medication and taper really gradually, or titrate up really gradually. And so really working with them on their experience with medications, if we're going to do the medication piece. And then the other thing in terms of medication is we do use buprenorphine for chronic pain quite a lot. And we use a microinduction. So the old school method of putting somebody on Suboxone was you put them in horrible withdrawal and they hated it, and then you started Suboxone. It's quick, but it's dirty, it's messy, and people don't like it. Microinduction, you can start somebody on Suboxone at home, in the community, comfort of their home, with no side effects whatsoever. And it's something that's really easy to do once you know how to do it. So we have lots of other tips and tricks, but I think I will turn it over to Sandra.
Awesome. Thank you, Jessica. Before we dive into the case presentation, we wanted to get a sense from the audience, how many of you actually prescribe buprenorphine for chronic non-cancer pain in your practice? So if we could put up the poll. I'll just give people another 10 seconds maybe. Okay. All right. So it looks like it's split 50-50. So that's really encouraging. I look forward to the discussion that we'll have later on. We can go back to the slides. Okay, perfect. So we wanted to give an example of sort of a typical client that we would see here at iPark. This is a lovely 45-year-old lady that we saw recently. She has complex, long-standing chronic pain, many different diagnoses, including widespread pain, pelvic pain, low back pain, facial pain. She also had abdominal pain that was complicated by this sort of chronic nausea, vomiting, and a very significant history of trauma, including sexual abuse. And she was referred to us for optimization of her pain management and mental health diagnoses. She had excellent goals. So she wanted to get back to school for UX design. She wanted to organize and clean up her apartment, and she wanted to go grocery shopping. And all of these things, her pain and chronic fatigue associated with that was a barrier to her achieving these goals. So again, she had many different medical comorbidities, the most salient of which are listed here. So fibromyalgia, Crohn's, she had endometriosis, pelvic pain, long COVID, PTSD. It's not listed here, but she also had a remote history of alcohol use disorder, sleep disorder, and many other medical challenges. So after a comprehensive case or a comprehensive assessment between Jessica, Nicole, and myself, these were some of the medications that she was on. So polypharmacy is very typical in the client population that we see. What's actually different about this case is that her morphine equivalent dose was much, much lower than we typically see. So she was actually at 90 milligrams of morphine, which is the watchful dose recommended by the Canadian guidelines for opioids for chronic non-cancer pain. But she was also on many other CNS depressing agents, including diazepam, zolpiclone, gabapentin, quetiapine, trazodone, and dimenhydrinate, which she was administering IV, all of which increases her risk of opioid overdose. And so in terms of our recommendations, the medication piece, I'll start with that and then I'll hand it over to Nicole. So our top line medication recommendation for her pain was a switch from morphine to buprenorphine. Again, Jessica alluded to this, but the rationale for this was its superior safety profile, along with demonstrated evidence in chronic non-cancer pain. There's different ways to approach this. We could do this with traditional induction, where we would stop the morphine long-acting for 24 hours, short-acting for 12 hours, or that microinduction, which tends to keep patients more comfortable and significantly lowers the risk of any withdrawal symptoms. And we also recommended just generally tapering her sedating medications, which was in line with her goals. So she was reporting the sort of daytime somnolence, and specifically with quetiapine and gabapentin, she was reporting some weight gain. So we don't do multiple medication changes at the same time. So we agreed, the client agreed that the priority was the switch to buprenorphine, but then this is something that we would tackle down the line. So I'll let Nicole speak to the mind and movement piece. Thank you, Sandra. So you can see we offer this three-pronged approach when we're at the end of the assessment, when we are sharing our recommendations. And so my expertise is more in the mind and movement, but I did want to just highlight that even like thinking about a medication rotation, she had a lot of anxiety about doing that. So we created a comfort and safety plan with her so that to really like hone in on what she was concerned about, and helping her, or we asked her to share her signs of distress so that we would be able to recognize what that would look like for her, what she would like from us as a healthcare team to best support her, and what strategies were most helpful. So actually in this case, she said, please don't talk to me about breathing techniques and mindfulness. Like, that's just too much. That's too triggering for me. She preferred physical modalities like walking her dog. So during the rotation, we actually would take her and go for a walk with her dog, and that was really helpful. So we really try to tailor the treatment to the individual. In terms of mind or psychological interventions for her and for most of our clients, we do a lot of psychoeducation about, what is chronic pain? How is that different than treating acute pain? And exploring a little bit more about that mind-body connection between pain. We review a lot of the psychological impact that chronic pain can have on someone's life. So we, exploring with her what that was like for her currently, and also asking questions around, what was going on for her during the onset of her pain conditions and what sort of things exacerbated her pain conditions. In this case, one of her conditions sort of exacerbated at the time of a significant relationship loss. And so important to acknowledge that, connect her with the relevant and important mental health supports as well. And of course, we want to explore things like the functional impacts of her pain, and recognizing that it's a continuous process. So we don't just get all of this information at one place or at one time. A lot of information is sort of uncovered over time. And so in this particular case, over time, her physical pain symptoms actually improved, and she was feeling like she said, a little bit more clear mentally. But then what happened was psychological pain and suffering started to emerge that was possibly being masked or numbed by previous sedating medications. And so now those areas are requiring some more further attention and support. And we also facilitated some connections with peer support and social networks to address feelings of isolation and loneliness that can go along with living with chronic pain. And lastly, in terms of movement, we suggested some self-release techniques. So myofascial release with it's really relatively simple intervention. We gave her a lacrosse ball. She had some really significant areas of tension in her back, and taught her how she could practice some strategies to relieve tension there. And it actually, empowers her to take control of her pain management as well. We referred her to a treatment program, post-COVID treatment program, and leverage community resources where we can. And we try to do that as much as possible. Also encouraged her to join a Facebook group related to her conditions, where she has said that's been really, really helpful in getting a sense of belonging and understanding, talking to other people who really get it. And importantly, we focus on setting specific, measurable, achievable, relevant timeline goals. And continuing to work with her to identify things that are really meaningful for her that she wants to engage in on a daily basis. So, just to sort of summarize the approach. So we use this 3-pronged approach, just acknowledging that opioids or any medication is just one piece of the puzzle. It is important, but it's a piece of it. And that instead we want to emphasize, there's a code. We want to emphasize the need to consider other multiple factors that could influence pain and paint someone's experience of pain, and really focus on the shifting the conversation to what are some things that can improve your function and your quality of life, and away from the focus on the numbers on a pain scale or the quantity of certain medications. Both from the perspective of healthcare providers and also of the patient generally, it can be incredibly empowering to have conversations about what are some other effective strategies that you have control over, that you can access to support your recovery journey.
Thanks, Nicole. And another big piece I think that we do, that we were talking about, like, what do we do to help during, like, what's changed in the opioid crisis, is dealing with the stigma. We really try to connect with family doctors and nurse practitioners and with pharmacists. And I often will write specifically on prescriptions like, this is Suboxone and it's for pain, no observed doses, patient does not have an opioid use disorder if they don't, and when we don't do like we don't do observed doses, and it's not the same as with methadone, but really working with our community providers to really support patients so that there's less stigma when they do go. And then just very quickly, because I recognize how long this presentation has taken out of our hopeful discussion, I just wanted to share some resources because honestly, anybody can do what we're doing. It just takes, some resources and some knowledge and some experience. We absolutely use TAPME. I mean, TAPME is our own hub, but we refer to other people in TAPME, and anybody can refer to TAPME who's a provider, a physician or a nurse practitioner. So there's a link there. There's a Power Over Pain portal, so the patient can sign up, and they've got all different, depending on what questions you answer, they've got different educational sections on different parts of pain, whether it's mood or sleep or medications. And then, explore your own local community. Massage therapy schools will usually do free to very low cost massages, especially for patients with pain. There are low cost acupuncture clinics, like there's one in Toronto that's a Chinese School of Natural Medicine. It's $5 and a can of food for the food bank. So lots of options there to look into. And then in Toronto, the Mind Body Pain Clinic offers seated Qigong. So it's like a seated Tai Chi plus a mindfulness component, and it's OHIP covered. There's no referral needed. They do have a virtual one you have to sign up for, but the in-person is just show up. Lots of peer support. So Chronic Pain Anonymous is a great online group. It's not a bitch session. It's really a very well moderated group. And it's actually, I want to say it's global, but it's definitely North America. And that's free and patients can access that. Just to be in a community where people understand and have experienced the stigma around opioid use or pain. And then for providers, I love and am a hub member of ECHO Chronic Pain Ontario. So every week we do an 1.5-hour session. It's free. We do a case presentation. It's anonymous case, but people bring cases they're struggling with that are chronic pain cases. And then you get all the input from all the specialists on the hub and from the community. And then you get a didactic presentation, and every week there's a different topic. So it might be on interpreting urine drug screens. It might be on fibromyalgia. It might be on low back pain. And so that's a great resource. Anybody can sign up at any time. And you can always call a friend or colleague. Our information's at the end, but we're always happy to lend support to our fellow providers. In terms of buprenorphine, so the college, so CPSO, at least in Ontario, and the Nurse Practitioners Association, College of Nurses of Ontario, require that you be competent in practicing and have taken a course. So there is a free and easy course that you can take that doesn't take very long that explains how to use Suboxone, how to prescribe it safely. And then, of course, include the community pharmacists and everyone around you, families, everyone, loved ones. And then there's a really great video if you have 3 minutes to watch it. It's one of the best things I've ever seen. And that's talks about stigma, but it really it really hit home for me. So thank you so much. And again, there's our email if you want to reach out to Nicole, Sandra, and I at any time with questions or if you need support around chronic pain. And I think we're ready for our panel discussion.
Absolutely. Thank you, everybody, so much. I'll just leave that slide up on the screen for just maybe another 30 seconds, just so everyone can copy that down. And I will also type that into the chat. All right. And there's a link to the referral form as well from Nicole. Thank you so much. Okay, so this is the time for you. This is the time for your discussion. And maybe while people are sort of digesting what they've heard and thinking about what they want to hear about, I have a couple of questions that came to mind for me. Of course, we're just going to do this for a second. And the first one was for Kylie. And I was wondering, Kylie, in your journey, especially since Ehlers-Danlos came into your life and things like really got intense for you with the medical, in a medical way, is there one thing that a clinician has done that has stood out to you as like just a super helpful moment? Like one time where you thought, oh, this is actually going to be a little bit more okay than I thought it was.
Can you hear me? Sorry, I tried to unmute myself and then I took the camera off, so it's one of those days. There's a couple of things. I think I had a pharmacist who was engaging. He'd have a conversation with me every day, look me in the eye, ask me how I'm doing, making a plan with me that I'm involved with, so I knew what was going on. Actually, I had a pharmacist who would save candy for me because I am quite a sweet tooth. So just knowing that he had like a box of Smarties for me and he knew that about me, he knew things that were helpful just to bring the conversation and open the conversation and create kind of like a bond, because you feel so isolated and you're kind of like, oh, I'm doing this, and sometimes pharmacists, it feels like there is no connection. So just to have a connection and just to know that I mattered was like so much to me, that like he took the time just to say hi and stuff. I think that was so important for me.
Thanks so much. And I'm going to invite any of the clinicians to sort of, and I apologize for just referring to you as a group, as to whether that resonates for you, like just what you just heard from Kylie about, like the simple connections. Is that what you're finding is making, you know, some of the difference when people come to your clinic?
I mean, I love that, Kylie, because it's you know, highlighting the human experience in between the clinical moments. It's like those little pieces, like knowing that you liked like the Smarties. I like that pharmacist as well. I want some of those. But yeah, I really like that, and I think that certainly resonates with me. Just like showing the compassion, and like regardless of what. I mean, it's important what happens clinically, of course, but I think really important is like those moments in between and just showing that we care. And I feel like we do that well, I hope. But it's really nice to hear from you how that has impacted you.
I think a good example is that I think we know every pet of every patient, and we've seen pictures of almost all of them. We're very keen on knowing who's in your home, and that includes your pets, because pets are really important. And so we try to make an effort to know, you know, the life of the patient, because I do think it's important. And you can't treat somebody if you don't know what's going on in their day-to-day existence, right?
Yeah.
I'll just add that as the pharmacist on the team, I've made a mental note to keep some Smarties on hand for rapport building.
There's that brand new outpatient pharmacy, and maybe we can get a bowl installed there permanently as well. So kind of a similar question for the iPark team, just thinking about your various practices. And wonder if there was any particular sort of learning moments that you had about patients with chronic pain that came from them, and specifically from serving them, you know, within the context of this interprofessional pain clinic.
I can start. This is a very simple statement, but I had one client say to me, it's really hard not to take a pill for pain when you're in pain. And almost like the simplicity of that was very powerful to me. So I think it really emphasized that I can't be effective alone. I need to work in the team, because there's so much beyond just the physical effects that the opioids provide. Like there's such a mental attachment to them. And I think that's where like, the whole team comes in, and that three-pronged approach of like mind, movement, medications helps clients reach their goals.
Thank you. Anyone else have a moment that stood out? I know there's so many. Think about it. Let's go to this one from Peggy in the chat. And she's asking why we need to categorize patients as pain or addiction patients, and wonders if we couldn't reduce some of the stigma and negativity if we just had patients. And sort of some thoughts about, I think we don't treat clients in a medical model because clients would get more choices. I wonder if you had thoughts about any of that, about that categorization especially.
I would absolutely love to see patients just being treated by their community providers and not needing specialty clinics. My end goal is that we won't be needed anymore. Honestly, I think we would love to be able to shift the focus so that patients are just treated as patients where, in their home base. But there isn't the education, right? Providers aren't provided. We haven't done a good job of training our nurse practitioners and doctors and social workers and OTs and pharmacists how to manage patients. So we become this weird siloed specialty clinic, and that's not what we should be. And I think, what we do here is that we try to empower, because we can't keep patients forever, right? We couldn't take on new patients if we just kept everyone forever. So we sort of try to assess and make some suggestions, and then we shift them back into the community where we can then teach. And we often do visits with the GPs and the NPs and the family health teams to try to augment the services so that they feel empowered to do this. And then maybe the next patient, they'll be able to do it more. Because we shouldn't need a specialty pain or addiction clinic. We should be able to deal with that just as part of routine care.
Thank you.
I agree. And like in preparing for this presentation, it occurred to me like the 3-pronged approach we use and anything, it would apply to anyone, right? It's not necessarily like this isn't necessarily like specific to someone who's been struggling with substance use. This is just management of chronic pain. And regardless if someone has a history with substances in some capacity, shouldn't preclude them from just getting their pain treated and thinking about all these different aspects of managing pain. So yeah, I agree. And I agree with what you were saying, Jessica, as well.
All right, I'm going to ask for a word of advice while I see that there's somebody else typing, but just in the meantime. So I'm going to ask everybody for a word of advice, one for a patient who is newly acquired a chronic pain condition. If you were to start seeing somebody for the first time, what do you think is the most helpful thing that they could hear? And that's for everybody. And the same thing for a clinician who's starting to deal with a population or wants to learn differently. What would you want a clinician? What's one thing you think would be really helpful for a clinician to know? And that's open to anybody because nobody knew these questions were coming. Kylie, why don't you start? I want to know what the advice you would have for someone diagnosed and for someone who is starting to treat them.
I think you have to accept yourself and where you're coming from each day. And I think that's hard because each day we feel different. So sometimes I find like, I can get down on myself, but I realize that I have to slow down and smell the roses. I use assisted medical equipment. I use a chair now. So I celebrate little wins, and getting up in the morning is a win. Writing in my journal or completing like this is a huge win for me. So just knowing that my doctor kind of in that Toronto General he kind of did pain psychology, and it was like keeping yourself in the positive is helpful. But we all have days where we swing all over the place, but it's just knowing that not every day is going to be the same. You move forward, you move backwards, but there's always a progression. And I think the biggest thing I would say to a clinician is I'm not showing you how I feel with my face. I'm not really giving you what is going on under here because I'm so good at masking it to people around me, friends and family, because I notice people get uncomfortable when I show a sign of pain. So I'm even like creating kind of a stigma in myself to show pain. So just coming from that point, we're going to try our best and we have days. But yeah, it's so hard and we've learned to mask. So even asking questions about different things, about dogs, about family can create like a connection where the mask can be dropped. And I think that's important.
Thank you. Anybody else have thoughts on that one?
Sort of along the same lines, not as positive as Kylie, but the importance of advocacy and self-advocacy. And unfortunately, the system is not made to help people in a way that is often accessible to people, and being able to advocate for yourself or having an advocate, someone that you trust. And I love what you were saying, Kylie, about not showing what you're feeling necessarily. And we certainly see that. And I'm a big proponent of narrative medicine. And I love to have patients write down. I say, you've got a lot of thoughts. Why don't you write it down? Because it feels really intimidating when you're in a room, in a clinic. Maybe there's 3 of us at the table, maybe it's just one-on-one, but like it all comes at you at once. Think about it, write it down, bring it in or email it to me, and we can kind of go over it. Then you have the time to think about it and put it into words and express what's going on. But it's a way of advocating that doesn't always feel so scary, I think.
Thank you. Anyone else?
I have, sorry, so my an answer sort of for both, like to the patient and to the clinician, is to really explore pain as like multidimensional. So our mentor and leader in the clinic, Dr. Andrew Smith, always like, pain is pain is pain. So psychological pain, physical pain, emotional pain, it all kind of comes together. And so particularly from like an OT perspective, I see a lot of times where pain impacts function and loss of being able to do the things that you used to love to do. And so exploring that and helping people for like the person with pain, but also as the clinician, to really help support people to get back to doing things that they love to do, but maybe modifying it in a certain way. And, you know, like Kylie, you said, like using tools to help do that, maybe modifying how you do that, figuring out what part time of your day that works to do that, but kind of rebuilding that back can be so helpful. And even I think a lot of times has a bigger impact than just like, your pain levels going down. But if you're doing the things that you really like to do, like that can be pretty profound. So that's my piece.
Thank you. We've got about 3 minutes left for one last question, and I see one in the chat that I wanted to pass on. Do you find that buprenorphine is just as or more effective for pain management than their existing opioids? I've tried a few times, but found that bup wasn't entirely effective, keeping in mind it's a multidisciplinary approach and not just medications. Anyone have thoughts on that?
Oh, that is such a great question. I'm going to jump in before Sandra, because I know Sandra's got something to say. I was thinking about like a moment with a patient, and I had a moment with a patient who was taking Percocets, and we were trying to get her off the Percocets. She had diabetic neuropathy, and she said, "But I take it and I feel good." And I sort of was stumped, and I didn't know what to say, because I was like, "Oh my God, of course you do!" Like, if I have a martini in the middle of the day, I feel good, but like I can recognize that that's not a treatment plan. How do I translate that? And I think that's often what we see with Suboxone. So absolutely, head-to-head studies. They've done studies with Suboxone post C-section. They've done it with abdominal pediatric surgeries. It has absolutely amazing analgesic properties as a chemical. What it doesn't have is that nice dopamine hit that a lot of the other, especially semi-synthetic hydromorphone, oxycodone, fentanyl have, that feel good. And so it works, but it doesn't work because it doesn't kind of give you that little boost that some of the other, especially the short-acting opioids, give you. And I often find that that's what we run into. And so then it's a conversation of, what are we treating? What effect are you getting from the opioids that you liked that you're not getting from the Suboxone? And sometimes actually just, confronting that hard truth. Sandra?
I think you touched on most of it, that sort of like non-physical pain relieving effect that people derive from other opioids. On like a more positive note about buprenorphine, what we often see in folks who are maintained on like higher doses of opioids for a longer period of time, they develop paradoxical worsening of their pain, the hyperalgesia. And or if they're on short-acting opioids, that roller coaster of like on-off effect, the peaks and the troughs. Switching to buprenorphine, even if it doesn't in that particular patient have like an intrinsic analgesic effect, just simply not having those ups and downs and no longer having hyperalgesia, that in and of itself helps to reduce their pain.
Wonderful. Thank you so much to all of our panelists, Jessica, Sandra, Nicole, Kylie. I don't know about anybody else in the room, but I have learned a ton today, and I'm sure I'm not alone. Thank you so much for sharing your experiences, clinical and personal. And to everyone attending, thank you so much. Reach out, keep learning, and have a great rest of your conference.